Thank you for the invitation. I'm Dr. David Baewer, Chief Medical Officer at Coppe Laboratories. I'm going to be talking about arboviruses as a possible cause of chronic Lyme disease. So the objectives today are to discuss the role of arboviruses, what they are, and how they could be are involved in tick-borne diseases. Provide information on Powassan deer tick virus. They're both very similar viruses, and how they affect tick-borne illness patients. And then we'll present some Powassan deer tick virus research that we have performed and how it may explain the symptoms of post-treatment Lyme disease patients. So this is the business end of an Ixodes scapularis tick. I'm a pathologist, so I like taking pictures. I had this tick under the microscope and I looked at it, and that's quite a formidable mouthpiece that they have right there. The barb is quite something to look at, magnified quite a bit. So as we know, ticks carry much more than just Lyme disease. Here's the 3 different types of ticks that cause disease in the United States. It's hard to see the pattern on them, but you can speciate them based on the cape and gender of them based on the amount of cape that they have. One thing that I like pointing out is the majority of the ticks that I've pulled off me and my kids are the wood tick, the dog tick, and they're really big. I mean, you can see them. They're like 1/4 of an inch big. But the ones that carry Lyme disease, specifically the nymph, which is responsible for transmitting the majority of Lyme disease, is very, very small, the size of a pencil head. So these aren't ticks that these aren't the big ticks that you see on you that transmit Lyme disease. It's these little itty bitty tiny ones that transmit Lyme disease, Anaplasma, Babesia, Powassan, and Borrelia miyamotoi. So what is an arbovirus? An arboviral disease is just taken from the letters arthropod-borne viral disease. So arthropod being a tick or a mosquito. The tick-borne arboviruses are very, very prevalent in today's popular press. Everybody has heard about Zika virus. Frieden, the head of the CDC, just this last week has had an emotional plea for billions of dollars of research for the Zika virus therapies and treatments and diagnostics. The arbovirus is also very well known as West Nile, St. Louis encephalitis, and chikungunya. Tick-borne encephalitis virus is transmitted by ticks. It's a humongous problem in Europe and Asia that I'll talk about. It's brother, sister, Powassan deer tick virus is the tick-borne encephalitis virus complex that's prevalent in North America. And also Heartland-Bourbon virus. There are other viruses that are less common but cause severe illness that are transmitted by ticks.
Question for you.
Yes?
Why is the Zika virus getting so much attention over Lyme?
That's a very good question. And if you look at the number of infections, I mean, it's 100-fold, 1,000-fold difference. Zika virus is getting the attention that it is because it's causing mutations in babies. And when you look at, the morbidity associated with an infection, if it causes a mutation in a child and they're disabled for their entire life, the impact on the population, the impact on health is so much more profound. Not saying that chronic Lyme isn't profound. I don't think chronic Lyme gets the attention that it should, but that's the reason, is because it's been found to have fetal malformations.
It just seems a little lopsided.
It is very, very lopsided. They're looking at giving a couple of $1 billion to Zika research to prevent these malformations from happening.
Most of the people that have the virus are picking it up somewhere else in some other country?
As of right now, there's been no local transmission of Zika virus in the United States. It's all been patients that have brought it here. But the vector, the Anopheles mosquito, is present here. So all it really takes is for enough people to come back here with the virus in their bloodstream and the mosquitoes here to start feeding on them, and then they can transmit them to transmit it. We'll have a local transmission of
If you go to
Zika.
the doctor, instead of asking if you've left the country, they're now starting to ask you if you've had sex with somebody that has Zika.
Right, and it's sexually transmitted, which is something that's been very controversial for Lyme disease for a long time, but there's been evidence showing that Lyme disease can be. The flaviviruses do look like they are definitely sexually transmitted. But yes, I'm gonna speak a bit about the potential benefit for tick-borne illness patients of the Zika research funding in the potential future. So tick-borne encephalitis virus is very, very closely related to Powassan deer tick virus present in the US. Again, the family of flaviviruses contains Zika, yellow fever, dengue, West Nile, Japanese encephalitis virus, Powassan virus, and hepatitis C virus. So all of these belong to the flavivirus family of viruses. The reason that I talk about hepatitis C here is here's a crystallographic structure of a protein of the hepatitis C virus and the Japanese encephalitis virus, which causes tens and tens of thousands of encephalitis cases in the Philippines and in Japan. That these protein structures are very, very highly conserved among this family, and millions, billions of dollars has gone into drug development for hepatitis C that has come out and that target this molecule. So potentially there could be some use for these hepatitis C drugs for these flavivirus patients in the future.
So that might be an answer right there to our question, is that they're looking at drugs to change it, and drugs are very lucrative.
This one is $40,000 a month.
Oh.
Yeah, it's very lucrative. They're going to get the attention.
Yeah, so it's not a good answer right now, but yeah, this drug is $40,000. Harvoni, the drug I'm talking about, is $40,000 a month.
So it's going to get a lot of money.
Well, yeah, that's why there is a drug for it, is because billions of dollars went into research,
Right,
and now they're charging that much money.
right.
For it.
And with Lyme disease, that mostly the drug that's used as antibiotics, which is not very expensive, so it's not going to get much attention.
No,
And sometimes I think that's the answer. I mean, that's
Right.
the answer as to
Drugs,
why,
the cost,
or the cost.
profits.
That is why the government's now looking at Lyme as being a real
Mhm.
thing,
right,
because the drugs aren't gonna kill it.
right. And what I'm talking
Or the
about
drugs
today
that
is
are-
the potential for another tick-borne pathogen to potentially be causing the symptoms, not Lyme, not the spirochete, not the Borrelia, which the antibiotics do an okay job with. It might be something other than the bacteria that's causing the symptoms. And that's what I'm talking about, and the potential for therapies for that, because right now there are none. In Europe, in Asia, it covers a very good portion of Eurasia. This is TB-EV, tick-borne encephalitis virus. It causes up to 15,000 cases of hospitalized encephalitis every year. It's underestimated because in Russia and a lot of other places, they don't have mandatory reporting and they don't have very organized healthcare as of yet. One of the things that's really important about TB-EV is that chronic and permanent neuropsychiatric sequelae occur in a third to about half of these encephalitis patients. So they have this post-encephalitis syndrome that has neuropsychiatric memory problems, cognitive impairments, fatigue, and these symptoms kind of mimic what a lot of the patients with chronic Lyme have as well. So it's been such a big problem that Switzerland, Austria, and Germany have implemented national vaccination programs for this. And you can see why. In the 1990s, the average incidence of TB-ED went up 400% in Europe. In Lithuania, it went up 1,000%. In Germany, it went up about 574%. Austria implemented a vaccine in 1981, and you can look at the incidence of TB-ED in Austria because of that. So this is how big of a problem TBE, which essentially is the same thing as Powassan deer tick virus in Europe. They had their big epidemic. It came to fruition that it manifests in hundreds of thousands of patients, and they acted on it, but it's still growing in some of the countries that don't have the vaccination program. So looking at the tick-borne encephalitis virus clinical course, they have a headache, fatigue, and malaise, an initial presentation that's indistinguishable from any other tick-borne illness presentation. The majority of the European TB/EV infections are subclinical, meaning they get a headache, they get sick, but they don't get sick enough to go to the doctor. About 30% of the ones that do get sick enough, that do get really sick, go on to get a meningoencephalitis, and that's the 15,000 cases that I'm talking about that are in the neuro ICU, you know, getting close to being on respirators.
This is in Europe?
This is in Europe. This is in Europe and in Asia. And about a third of these patients, like I said, go on to have this post-encephalitic syndrome where they have these neuropsychiatric symptoms that last for the rest of their life.
Is there testing for that?
There is. We actually utilize a component of the testing from Europe in our diagnostics because they are so related. So looking at the TB/EV diagnostic testing, by the time you're sick and in the hospital, there are IgM and IgG antibodies, so serology testing can be done. In the very early phase, before that, before antibodies have been developed, you can detect the virus in the serum by polymerase chain reaction, or PCR. PCR, detecting the spirochetes, Borrelia, for Lyme disease, has very, very little clinical utility. The amount of spirochetes in the blood is very, very low and very, very short-lived. So we don't use PCR for Lyme disease, but in this virus, there is a good amount of virus in the blood for a good amount of time, so PCR is utilized here.
And we're still talking Europe here, as far as.
This is TB/EV, yes. But I'm going to draw the analogy from TB/EV to Powassan because only the patients that have pretty much been hospitalized here in the United States and had their blood sent to the CDC, there's only 60 cases of Powassan in North America so far. So there's very, very little research and clinical understanding of how the disease progresses. So we have to look at TB/EV as a correlate to try and understand what Powassan would look like. So there is no treatment for TB/EV. It's supportive. Immune globulin, I mentioned before, possibly the HCV drugs. And here's where I mentioned that the potential for the amount of money that's going into the Zika drug development may be helpful for these patients as well, and yellow fever and dengue. I mean, it's a humongous problem around the world that doesn't have any real answer because they often occur in resource-limited areas where you're not able to have these patients pay $40,000 a month for an antiviral. If this drug gets developed for Zika because of this emphasis on it, be it an overemphasis or not, the potential for flavivirus drugs being developed and to be able to be used for these types of patients, I think, is exciting.
Wouldn't there be some crossover for Lyme patients also with the yellow fever and this?
Correct. The tick-borne and illness patients and mosquito patients, all of those patients. I mean, if you're out in the woods, you have environmental exposure, you have the potential for getting any of these infections. These drugs won't be helpful for Borrelia, for Lyme disease in particular, but for the co-infections that I'm talking about, yes. Where there are currently no drugs available for these infections, potentially there will be with this emphasis put on Zika. So right now, when these patients are in the hospital, they just do symptom interventions. If they can't breathe, they get intubated. They try and limit the swelling in the brain. There is an effective vaccine available in Europe for TB/EV. It's not known as to whether or not there would be sufficient crossover for a TB/EV vaccine for Powassan deer tick virus here. So Powassan deer tick virus, a member of the TVED complex. So it was actually discovered in Ontario, Canada in 1958 from a little boy that died from encephalitis there. They isolated the virus in 59. And so deer tick virus and Powassan virus are two lineages of essentially the same virus. They're called lineage 1 and lineage 2. So they're indistinguishable from serology. So with an antibody test, we cannot tell if you have deer tick virus or Powassan virus. There is some DNA sequence difference, but you'd actually have to do the PCR and then have deep sequencing sent out to distinguish between deer tick virus and Powassan virus. One of the things that is a little bit different is the deer tick virus. It can be in a different tick as well, the Ixodes ricinus, and the Powassan virus is mostly in the Ixodes scapularis. And the important thing that makes this virus important in this population is that it's transmitted by the same tick that causes Lyme disease, the Ixodes scapularis, the deer tick. One game changer, though, however, is this right here. Is if you look at the transmission time required for Lyme disease for Borrelia exists in the questing tick in the gut. When they attach to a human, they take a blood meal, the Borrelia proliferates, migrates to the salivary glands, and then is transmitted to the human. So there's differing time frames that have been quoted, but usually it's quoted over 24 hours of attachment is required for sufficient, efficient transmission of Borrelia, of Lyme disease, to a patient. Powassan can be transmitted in 15 minutes. Powassan infects the salivary glands. And so upon biting, upon attachment, it's available for transmission. Yes?
How do you determine the number of hours that a tick has been attached to?
Well,
Think about it.
the engorgement size. There are if you look at an unengorged tick compared to a fully engorged tick, you can look at the time frame for which it's been fed, the exposure. If you do the tick checks every day, and you know that it's you do a tick check at the end of the day, and you don't have any, and then so the next day you do a tick check, and you find one, it's been within that day. One of the big game changers for this is that end of the day tick check isn't potentially sufficient, because if the tick is attached for 15 minutes, you can already transmit the Powassan virus.
How do you prevent it? How do you get, because there is things we've learned from Australia that they have a motto of freeze, don't squeeze, that you use an aerosol that you use to spray what you normally use on warts to
Right.
freeze them. But you do it on the tick and freeze it, and then it just all comes out.
Mm-hmm.
So what do we carry that thing around with us, or keep it in our?
Yeah, it prevents the repellents, pants, the permethrin coated clothing. This is where like the prevention is of utmost importance, because just a very short amount of tick attachment can cause transmission.
Will permethrin help avoid this virus?
Yes. Yeah, permethrin kills the ticks when they climb on the clothing. Mm-hmm. Absolutely.
Just don't put it on your skin.
Right. Yeah, permethrin is just for the clothing.
The army puts them right on their skin.
Well,
That explains some things.
That's who invented that.
That's where the.
so the clinical diagnosis of Powassan and deer tick virus, it usually takes about a week to manifest. The fever, muscle weakness, confusion, headache, nausea, vomiting, stiff neck are very, other than the stiff neck and potentially the vomiting, it's very, very similar. It's indistinguishable from the flu-like illness that you get from Lyme disease or many other infectious agents. The severe signs are the respiratory distress, the seizures, the gait imbalance, the confusion, paralysis, and coma. And these are the meningoencephalitis patients that are in the neuro ICU. And a good portion of these, about half of these patients, again, go on to develop that post-encephalitis syndrome or chronic neurologic sequelae after the infection, after the encephalitis.
You're talking about gait imbalance, and you're obviously talking about walking, how a person walks,
Correct,
balance issues.
correct.
I mean, doesn't that occur, I believe it occurs with people with Lyme or their
Correct.
Or co-infections.
co-infections, yeah.
Yeah.
All those things that we support.
So again, it's only supportive. Oh, the other thing about the Powassan deer tick virus here is that because there haven't been so many cases identified, of the cases that have been identified, 10%, 1 out of 10, has been a fatal case. So this is very, very severe diseases. We believe that like the deer tick, or like the TB-EV in Europe, that a lot of the cases are subclinical, or are making people sick, but not going to the overt meningoencephalitis like they do in, like the way it is in Europe, where 70% of the cases are low-key, and then only 30% are the encephalitis. But what we're talking about is that 70% that get the infection, and it's subclinical, what's happening to them? They have this virus, and it's not causing an encephalitis, it's not killing them, but it's doing, we believe that it's doing something.
So there's varying degrees of infection, of course, weak, strong, very strong.
Correct.
The same with Lyme, and it appears that they don't get Lyme, within 24 hours, you've got it. In other words, you've got to have a tick bite. Your chances of being infected within 24 hours are pretty great.
Correct.
Because there's all kinds of,
And I'll show that the Powassan and the Lyme go together in the ticks as well. So I think that if you're getting, and I'll show that a lot of the patients that we have tested that have Powassan also have Lyme, and so we are the only lab that has the commercial test. How we developed it, we actually have a BSL-3, a biohazard safety level 3 lab in our building. When I was a med tech at Marquette in the late 90s, there were only 2 BSL-3s in the state. The one was at the VA, where we did all the tuberculosis testing for the Midwest, and one was at the state lab in Madison. And we have one of those, so we actually got ticks from the field and isolated the virus from the ticks from northern Wisconsin, and we're using that virus in our tests. That's why it's a very, very difficult process to do.
does the VA get involved in much of this stuff?
The VA?
As far as ticks and, they don't, I mean, as far as, the mentality I'm picking up there is that it doesn't exist.
I have not seen any VA research on any of this stuff. One of the things about the CDC testing, especially right now, if you wanted to have something tested for Powassan at the CDC, they're inundated with Zika testing. All that they can do right now is Zika testing at the CDC and the state labs. So, and even a lot of those diagnoses that the CDC has given have been posthumous. That, like, the patients have already died by the time the result comes back from the CDC. So it's weeks to months before you can get a diagnosis from the CDC. And we do report to these tests to the state where they go to the CDC for.
Do you have any numbers, what the numbers are of Zika in Wisconsin?
0.
0.
But they're just recruiting, they're keeping the door shut at the CDC or the state testing.
Well, how many people have gone to the Caribbean? I mean, I have a handful of friends that are in Jamaica right now.
I'll be going there.
I'd like to go.
Right.
You're going?
Well, yeah, I mean, I don't. You have to look at the risks. I mean, right now there's no local transmission in the United States, but in the Caribbean there is. So you just have to look at what the local transmission is for the areas that you're going to.
Well, I was gonna go to the Cayman Islands where they have like a big health city facility.
So this is
But I
where
don't have to go, I don't
Where
have the ticket yet.
the cases of Powassan have been. So if you look at the numbers, I mean, the 3 states, Minnesota, Wisconsin, and New York, and when you look at the population here of New York State compared to these states, we have a lot of cases per capita. So when you look at the incidence by county of the Powassan virus from 2004 to 2013, you see a lot of that in northeastern Minnesota and northwestern Wisconsin. And this is really the hot spot for Lyme disease, and this is central Wisconsin, where there is Powassan and there is Lyme disease.
Wisconsin Rapids or something like that?
What's that?
Wisconsin Rapids area up in that area?
Yeah, that's it up here, right?
I'm just guessing the facts.
Yeah.
Yeah.
But this is like, when you look at the incidence, what's the rates, the number of infections per population, the risk is much, much higher here compared to over here. Yes?
Dr. Heath, how much of this do they think they're actually detecting?
Yeah. These, like I said, these are only the cases that were so sick that they were in the ICU. They did all of the other tests, and they were like, well, we don't know, let's send it to the CDC. And then it gets diagnosed. So those are the only cases that are really being reported right now. And that's the only way you can really get to testing. Since we've, yes?
What about treatment then?
It's supportive. There's no treatment for, as of yet, for these, for Powassan deer tick virus. That's why I was talking about the potential for, future drugs being developed for Zika, a very similar flavivirus. This is where I get into what Coppe Laboratories has done. We asked, could there be an infectious agent that is insensitive to antibiotics that mimics the symptoms attributed to chronic Lyme? So I've been talking about the presentation and the post-encephalitic sequelae of the Powassan deer tick virus and how it very closely mimics clinically Lyme disease. However, it's a virus. So we looked at a bunch of ticks in Wisconsin. We collected in fall, I'm talking about 2 different tick collections in 2011, 12, and 2014. We collected over 2,000 ticks. So they sent them in hydrated plastic bags, and we froze them, and we have to, like I was showing you the pictures, we have to speciate them in a German center into the dog tick or the deer tick, and then gender them based on their markings. And these are, you wonder how they stay alive through the cold Wisconsin winters. They're in the -20 freezer, and you have them out on the plate, and once they thaw, they start crawling. We had to use petri dishes with walls so they didn't walk away.
Yeah, it's supposed to be frozen for a long, long period in order to kill them, and we don't have
Right.
those periods anymore.
Yeah. Yeah, no, they were in a -20 freezer for months, for probably a year, and they still woke up. So we had over 2,000 of these ticks that we tested. We tested for Borrelia, Anaplasma, Babesia, and Powassan, very prevalent infectious agents in Wisconsin. To look at this northwest quadrant of Wisconsin, where it's an endemic zone, we know this is the area with the highest Lyme disease in patients, and we saw 42% of these ticks had Borrelia in them. Almost 7% had Powassan virus. So 6.8% of the ticks in this area had Powassan virus in them. Of note, 8% of them were co-infected, had both Powassan and Lyme disease, Borrelia. What I think is important is across the entire state, because we're sampling the non-really endemic areas for Borrelia, we got 11% Borrelia, because it's not as endemic in non-northwestern Wisconsin. However, we still saw 6% of Powassan. What this really says to me is that Lyme, Borrelia is more in the northern Wisconsin, but Powassan is in ticks all over the state. And a good amount, 6 to 7% of the ticks have Powassan in them. So what can we conclude? That an individual can acquire multiple tick association pathogens simultaneously. We know that these ticks carry more than one pathogen. That the Powassan deer tick virus is in a significant percentage of ixodes in all these studies, 6.8% across the state. So infection with the deer tick virus, Powassan virus, is very likely underdiagnosed. And the virus may contribute to the symptoms that are attributed to chronic Lyme infection with the Borrelia.
And you're saying antibiotics have no impact on Powassan?
That is correct. So how does this relate to human disease? I'll talk about another diagnosis. As a physician, chronic Lyme disease and chronic fatigue syndrome are very, very similar. The symptoms are very, very similar. Chronic fatigue syndrome is a diagnosis of exclusion. So if you have no tick exposure, you've never been exposed in an endemic area, then you have these symptoms and you can have a diagnosis of chronic fatigue syndrome. The symptoms, muscle weakness, pain, insomnia, cognitive impairment, are all very, very similar to Lyme, and it's a diagnosis of exclusion. So we did a study looking at post-infectious fatigue subsets of chronic fatigue syndrome. So these are patients that had an acute onset of illness. A lot of chronic fatigue syndrome patients, or some, have an onset where they don't really know where they specifically got sick. But a subset of these patients have a acute onset where they have a flu-like illness and then they never really get better. And so this really sounds like an infectious etiology. So I like to think of these post-infectious fatigue patients as a subset of chronic fatigue syndrome that more likely has an infectious trigger. So we looked at 250 post-infectious fatigue patients from 2 clinics specializing in CFS. And we tested for Borrelia and we tested for TB-EV. So that's the testing for TB-EV is very readily available from Europe, and those viruses are very similar. So the take-home message here is we saw evidence of Powassan virus, TB-EV virus infection in 11% of these patients. So these patients were probably already screened for Borrelia because they carry the diagnosis of chronic fatigue syndrome, and those docs do a whole battery of testing before they get to a chronic fatigue syndrome physician. And so more than 10% of these patients had evidence of Powassan deer tick virus TB-EV infection. I'm using those synonymously. In an unpublished study that we have from a manufacturer of the kits that we use, they looked in the northeast, the endemic area for Lyme disease, other than here, and got a bunch of patients come in from radios, and they saw about 15% of those patients had evidence of TB-EV. So these are real life patients that look like they have evidence, and this isn't 60 cases in 70 years. This is 15% of the population has evidence of serologic exposure.
And that's in the far northeast of Wisconsin?
No, this is in northeast United States, okay. New York, mostly New York. So this is a study that we just recently did. It's not embargoed anymore, so can I?
You can pretend.
Okay, yeah, I can say where it's from, right?
Yeah.
Yeah, okay, so we did a study with Marshfield Clinic, not far from here, and a children's hospital where we had acute tick-borne illness patients samples sent to us. All of them had recent exposure to a tick. 10.4% of these real-life patient samples from this year were positive by our immunofluorescent assay for Powassan virus. And this immunofluorescent assay is actually an assay where we use the Powassan virus that we grow in our lab and put the patient specimen on it to see if those react with it. So this is talking about that these are real life incidents of the Powassan virus in these patient populations. And this is an acute
But
exposure.
it's primarily being found in the upper part of the state, in other words, mid-level.
No,
going
this
north.
is Milwaukee.
Really?
Yeah, this is Children's Hospital. And the Marshfield is catchment is mostly mid to upper state, but a few of our patients were from Milwaukee. So Powassan isn't just in the upper part of the state.
How are these people being treated in the hospital?
They're just being treated for the Lyme disease. A lot of them, what percentage?
Which doesn't work for them.
Well, right. Some of them are subclinical, but the patients that present with Lyme and Powassan, that's very likely a different disease and will possibly need additional antibiotic treatment because the flaviviruses are known to be immunosuppressive. So, but we don't have a clinical follow-up on a lot of these patients, whereas the clinical laboratory, we did the testing. We're very interested in getting the follow-up because some of these were very, very positive kids with Lyme and Powassan. But if you remember with the TB-EV, 70% of those patients are subclinical. They fight it off. So that's probably likely what we're seeing. What we're also doing is a study looking at chronic Lyme patients, because I think that's the population that is really very, very important to study, because if the post-treatment Lyme disease syndrome, chronic Lyme, however you want to call it, you get treated with antibiotics, you still have symptoms. If you had Lyme and Powassan, you got treated with antibiotics, the Lyme went away, but you still have the Powassan. You still have symptoms from the Powassan, potentially.
Which mimic Lyme.
And so if you have a population of people that still have symptoms after Lyme because of a virus, that is chronic Lyme. So we're very interested in finding.
So the likelihood of that is real strong if you're still treating after 2 or 3 years with chronic Lyme. In other words, you've used all the antibiotics.
Right. And what I would like to be able to tell a clinician, for a patient like that's on long-term antibiotics for symptoms, if they come up positive with Powassan, that perhaps it's not necessary to treat with the antibiotics anymore, but look for immune boosters that help with the cell-mediated immune system to help treat the virus.
What would be immune boosters, briefly?
It,
Or is it very involved?
Vitamins.
well, right, yeah.
Everybody takes vitamins.
I think, how about we save that for last, because he's got a bunch of stuff he just wants to present.
So again, the conclusions is that the seropositivity in post-infectious fatigue syndromes to Powassan TB-EV suggests that Powassan irritic virus is very, very underdiagnosed, which we were talking about, and that the virus very likely or possibly contributes to these symptoms in chronic fatigue syndrome patients, which again are the same as chronic Lyme patients, and would very likely benefit from whatever type of therapy that might be available for this, this virus that might be causing these neurocognitive symptoms. So arboviruses are real. The true threat of the encephalitis is probably very low, but the threat of the chronic Powassan in a population like here, where we know it's here, is unknown, and that's why we're doing all of this research. This isn't CDC-funded research. This is all research that we fund with our own money, and that it's increasing. The symptoms are similar to Lyme. That multiple studies show that the ticks carry more than one pathogen, and that these arboviral infections could be the source of post-treatment Lyme disease. So now I'm going to switch gears to human herpes viruses. The lab that we're founded, that I'm with, is actually founded on HHV6 research. And HHV6 has very long been attributed to chronic fatigue syndrome. That's why we have a lot of research and passion for chronic illnesses. That's why when I say chronic fatigue syndrome and chronic Lyme are very similar, is I interact with a lot of these patients and a lot of these docs, and they're similar. And so everybody wants an answer. And as a pathologist, that's what I want to do. So HHV6, I honestly didn't know what HHV6 was, and I was in school for 20 years. MD, PhD, Johns Hopkins, I didn't know what HHV6 was. But we know what herpes is. We all know what herpes is. Herpes, like we know it, herpes simplex is HHV1 and HHV2. But did you know there's 8 HHVs? We know what varicella zoster is, that's chickenpox. Epstein-Barr virus, that causes mono. Cytomegalovirus, that causes all kinds of diseases. Kaposis, HHV6, I'll talk about. HHV7, we don't know that much about. HHV8 actually causes cancer, as well as EBV. So human herpes viruses share common features. They're all DNA, they all look the same under an electron microscope. One of the really important things about these viruses is that they go into your body almost ubiquitously. This is one of the most successful viruses in the world. I'll show a slide in a bit about how many people are infected with the herpes viruses. But once you get it, like if you have a cold sore, you get stressed out, you get sick, it comes back. With zoster, when you get really, really stressed out, when you're older, that comes back. HHV6 reactivates periodically with immunocompromisation when you do get sick. And a lot of these can come back together, which is really like a herpes viral swarm that I presented a poster at the International Association for Chronic Fatigue Syndrome meeting in San Francisco a couple of years, where I also gave a talk on the herpes virus serology. So again, healthy individuals don't really have a problem. When you're healthy, happy, running around, you don't get cold sores. When you're stressed out, you do, or when you're really sick. So dysregulation of the immune system can result in reactivation in any of these viruses. One of the things is like even a Lyme disease infection, it gets you sick, the HHV6 can actually reactivate. A lot of Lyme literate physicians will test for HHV6 to make sure that it's not reactivating. So I'll just go through the different human herpes viruses really quick. HHV1, cold sores. HHV2, genital herpes. We know those. Varicella zoster, chickenpox. I guess people don't get chickenpox these days. That's weird. I had chickenpox. My mom actually took me to a chickenpox party when I was little. Did anybody ever hear about those?
Yeah,
Took me over by
together, yeah.
No, the reason why I've seen
they brought me over by somebody's house that had chickenpox so that I would get it.
Yep.
That was vaccination in the 70s. But that's HHV3. HHV4 cytomegalovirus makes beautiful cells if you're a pathologist. Doesn't that look cool?
Like an alien.
Yeah, it's owl's eyes, nuclei. So cytomegalovirus, it makes giant cells, human herpes virus 5, EBV causes infectious mononucleosis. This is a blood cell, a blood smear, and you get these typical infectious type reactive lymphocytes. This is how we diagnose mono with a blood smear. HHV6 is ubiquitous. 100% of the population has it by the time they're adults. It reactivates periodically in the saliva, so that's why babies get it. I mean, kiss babies. They get it from your saliva. So all babies get it, but it remains latent in your body until something happens. If you get a transplant, a bone marrow transplant, 50% of bone marrow transplant patients will reactivate their HHV6. So it's a very, very big problem in bone marrow transplant. So what does it cause? It actually causes one of the very common diseases of childhood. It causes roseola, infantum. Usually this is, you get a fever, you get a rash, and it goes away, you have HHV6. Very, very rarely it can cause encephalitis in the little babies, and the fevers can be so high that you can actually get, the little babies can get the seizures, febrile seizures from it, but it's a very mundane childhood illness. Again, you get you get it when you're a kid. When you're an adult, a healthy patient, it reactivates in your salivary glands and you shed it. That's why everybody in the world has HHV6. However, in transplant patients and AIDS patients, or immune dysregulated patients that have other chronic illnesses, it can reactivate. And HHV6 reactivation causes fatigue, cognitive impairment, the exact same symptoms of chronic Lyme. So that's why Lyme litter physicians will test for HHV6 reactivation. And it has been shown to be a problem in Lyme disease, chronic fatigue syndrome, multiple sclerosis, AIDS, and cancer. All these are immune dysregulation states where it can reactivate and cause problems. Again, in their neurological symptoms and fatigue. And it can reactivate to other viruses. These viruses are so similar that molecularly, the genes that get reactivated for HHV6 can actually go in the nucleus that also has EBV or also has CMV and actually act on those and reactivate those. So I've shown data that the HHV6 and EBV often reactivate together. So one of the problems that we have with HHV6, however, is that serology is no good for HHV6. Serology looks to see if you've been exposed to an agent. Everybody's been exposed to this agent. So serology is going to tell you you've been exposed. Is that useful? No. So serology can't tell you anything. People will have titers and try and follow titers. When I was at the CFS conference doing my poster, the clinician would come up to me, he's like, how do you know when to treat? How do you know when it's active? So I went back to the lab and we developed a test. We developed a test looking at those genes and said, well, if this gene is active, if we can detect this gene, it's definitive evidence that it's a viral, it's a lytic infection, that the patient is sick because of this. And that's the mRNA test that we do that proves that the virus is active, which is, I think it's cool. mRNA, yeah.
mRNA.
mRNA.
They get this all down.
Right. So yeah, that helps to detect if it's active or latent. Well, H7, we don't know what it does. It causes some roseola cases. Human herpes virus 8 is kind of cool as a pathologist. It was originally isolated from AIDS patients where they had this Kaposi sarcoma all over. When you're super immunocompromised with AIDS, this causes a horrible sarcoma of your blood vessels everywhere. So this is what I was talking about for the serologic testing for herpes virus, why it's no good. And this is the estimated burden of chronic viral infection in humans. So this is the number of infected individuals. Okay, so like here is CMV, here is EBV, here's varicella, here's H6, here's H7.
Wow.
So that's the number of patients that are infected with these herpes viruses, and that's why I said serology really isn't any good, because serology detects exposure. They're exposed. Everybody has it, so serology really isn't very good. And one of the other problems when you're looking at serologic tests for infectious agents, Lyme tests are serologic tests. They're looking for antibodies. They're really sick. These are really, really sick people that are immunocompromised because they're so sick. They're not making antibodies. antibodies, and we're looking for antibodies. So it's a catch-22. We know that in AIDS patients or in transplant patients, we don't really use serology because we know they don't have antibodies. But in these really sick chronic fatigue syndrome patients or chronic Lyme disease patients that we know that they're immune deranged or dysregulated, but we're expecting to look at their antibodies to see if that they have a disease or not. Often those antibodies aren't going to be there. Yes.
Can you use DNA testing to test for the actual virus, or?
The virus, yes. For the spirochetes, no. That's one of the problems with the Borrelia and with Lyme disease. Remember how I said the virus, for the deer tick virus, the viremia in the blood is a high level and it's prolonged. So you have a good window period to detect the virus in the blood. The spirochetemia, the amount of spirochetes or spirochete DNA in the blood is very low and it's very short-lived. So if you look at the sensitivity of detecting, in an active infection, the spirochetes Borrelia DNA in the blood, it's very low. It's 30%. And so if you want to look at even other places in the CNS, so if you have a neuroborreliosis, it's still only about 40%. Even in a Lyme arthritis, where you know it's being caused by Lyme, it's about 40% sensitivity. So, less than half of the patients you're going to be able to detect. The best is if you have an erythema migrans, and you go to the leading edge of the skin and you take a piece of skin, and you PCR that. About 50% of the time you'll get it. That's the best you can do. And if you have an EM rash, do you need a diagnostic test? So that's never done. So that's just looking at how hard it is to detect the spirochetes in these samples. The virus, yes. The spirochete, no.
And supplements when treating with this, your basic, even good supplements have no impact on this stuff.
Supplements?
Well, your B's, your C's, your
We'll
D's.
get to that, Bill.
Yeah.
We'll get to that. I know,
So
we all
this-
want to know
this-
what we can do.
This has been in 2000. Dr. Knox, the founder in Carrigan, the founder of the lab, we're doing research on active HHV6 and chronic fatigue syndrome. This is just an abstract I thought I would put up there from 2000, so 16 years ago. Our lab, the founders of our lab were looking at HHV6 and chronic fatigue syndrome in chronic patients. So I'm a pathologist, I'm not a treating physician, and so to address your question on supplements, I would have to defer to a treating physician. I know that there are physicians that do find utility in some. I don't know what they are though.
Yeah, most of them using people, the really good ones will use the whole package. Antibiotics, supplements, the whole
Right.
thing. IV,
They have a whole treatment
the
regimen
whole deal.
that they have figured out that works for them.
Well, I'm totally depressed. I wanted to go out with my friend to the Cayman Islands, and I haven't even been out of Wisconsin in 200 years.
Well, drive down to Illinois.
You'll be fine.
Bug spray works.
There you
You'll
go.
be fine.
Yeah,
Yeah.
it's probably worse being in Wisconsin than Cayman Islands.
Yeah.
Because, for most of us, if you end up with the Zika virus, it's not gonna cause you a
Yeah.
problem unless you get pregnant.
Yeah.
You
So
gonna do
the-
that,
the-
Diane?
I'm way past
The
that.
travel warnings are really only for pregnant
And
women.
then you'll be immune to it afterwards, because your body will know what to do with
They
it.
don't have immunity. It's funny because you talk about supplements and what you need to do. And one of the things
Well, he said that, I think.
I thought was pretty funny
Yeah,
was,
it's bad.
go and have dental surgery now, and what will your dentist tell you to do after you have dental surgery? Use vitamin C, piles and piles of vitamin C. Now, back in the day when I was working research in a hospital, vitamin C was, your body took only so much and the rest of it got rid of.
Yeah.
So it was kind of like, why do I need more vitamin C now? Well, obviously, if you're immune compromised, you need more vitamin C
Yeah.
because you're not building up what you need to be building up, and you have to build it up faster, so you have to give yourself building your blocks for this.
So we're kind of.
And you gotta have bioavailable
Dave,
stuff.
what did they tell you for dosage for you when you were sick?
It was grams.
5 grams?
Yeah.
It was based on body weight. He would need 5 grams. Take a look at how big he is compared to you and figure appropriately.
But that was when you're acutely sick. Like when I had a bad cold,
He was-
and there's hyper supplementation, like when you're acutely sick is one thing that he was
Well, and
recommending.
you know, if you think about what we took for colds, we took airborne, correct? There was never any clinical research to prove that airborne was gonna work, but it had within it huge doses of vitamin C and magnesium and a little bit of zinc. Hey, we know all of those things work for the colds.
Well, there's a really good treatment for Lyme that's called vitamin C and salt, you know, the real
Okay.
mineral salts. And you scale up from like 0.5 on up to like, I think I was at 6 grams.
Yeah.
As I
One
said,
of
a lot of them do vitamin C.
one of the recommended dosage treatments is for Powassan virus that I've heard from a Lyme lawyer physician is vitamin C actually. But I think he's giving it IV.
Oh, yeah.
But
Lipospiric is actually better
Than IV.
okay, yeah.
It's liposomes.
Oh, with the bioavailability of it, yeah. Yeah, I'm not. I do the testing. Not the treatment.
If you
I'm
guys-
interested in it, especially because when I first started talking about Powassan virus to a lot of the ILADs, I'm a member of ILADs, I've gone to a dozen ILADs meetings, and I talk to them, and they're like, well, what are you gonna do? What if they're positive for Powassan, there's no treatment? And I'm like, well, there are things that a lot of holistic physicians do. And talking with them, I mean, if you have a bacterial infection or a fungal infection or a viral infection, they're gonna give you different supplements. They're gonna give you different regimens. And so I think it's important to know. I don't have the answers for what the treatment is, but I think there's hope for it.
Well,
Part of it is supercharging the immune system.
Yeah, absolutely. And it's the cell-mediated immune system, because bacteria is humoral, it's antibodies. Viruses are inside your cells, so you have to boost the cell-mediated. It's an entirely different branch of the immune system. And so I think that is, a different focus for the physicians.
What did you
Well,
say?
the salt is supposed to go in your cells, not the seed.
Okay.
The salt is supposed to go in the cells, and then the seed's on the outside of the cells, and when the bacteria die, it's like the seed washes it away.
What did you mention earlier? I missed that. You were talking with this gentleman in front of you.
T-cell? Oh, he was talking the difference between T-cell and humoral immunity.
Yeah. From cellular mediated immunity, so bacteria are predominantly extracellular and they get attacked by antibodies. And viruses, by definition, live inside of cells. And so when you have a virus, what that cell does is it puts the virus, it eats up some of the virus and says, crap, this isn't me. Puts it on the surface of the cell, and then other cells in the body recognize that portion on that cell as non-self, as virus, and it kills that cell. So that's entirely different than, the B cell mediated immune response for bacteria. So boosting cellular immune
I
response.
thought he had mentioned something that he was using or something.
We were just mentioning supercharging the immune system so that it's.
Oh yeah, the bioavailability of different drugs.
I was just gonna say, if you want treatment ideas, if you go on the website, go to the search bar, type in viruses, there's a whole article I wrote with various things that different Lyme docs have found helpful. There's ozone, there's UV light, all this stuff kills viruses.
Mm-hmm.
There's American ginseng, you got it right here.
There's all this, vitamin C, all of these things that basically, and again, I think sometimes we're asking the wrong questions. Sometimes we're trying to eradicate things, and sometimes you can't just have that focal point. You have to think a little differently. How can I make my body a tougher target? And that means many things for different people, and we're all different. But I think the thing that the take home today is that there could be other things that we're not considering in our treatment pictures that could be looking a lot like Borrelia, but are something else. It's in that other category.
That's a beautiful synopsis of what I was trying to say today. Yes.
Let's you better sound.
See, that's why somebody said, we shouldn't be calling it Lyme disease anymore,
Yeah.
we should call it tick-borne illness.